Hi, hello, and welcome to the Wisconsin Nurses Association's self-study module on patient-centered team-based care and its use for identifying and treating and monitoring patients with hypertension or high cholesterol. My name is Gina Denick Champion, and I'm the Executive Director of the Wisconsin Nurses Association. And I'm also Project Director for a grant that was awarded to WNA by the Wisconsin Division of Public Health through the Wisconsin Department of Health Services, with a larger grant that was provided through the CDC. We would like for you to be aware of two documents that are also that accompany this video. What they do is provide sort of the content for the video, but what it does is provide a concept of patient-centered team-based care, as well as some of the workflows that you might want to think about when it comes to managing your patients with hypertension or high cholesterol. So those documents are available on WNA's website. Also want to let you know that the way you can earn your contact hours, receive your certificate of contact hours, is you will be directed to link to our evaluation and survey. The survey includes questions that are important to WNA in terms of our grant. Your experience or your current status of your organizations, your particular clinic where you're working, or where your specific area where you're have implemented team-based care or thinking about it, again, with the focus on hypertension and high cholesterol. So I do want to thank you in advance for your interest in wanting to view our video, as well as wanting to hopefully promote the importance of team-based care to manage two very important chronic diseases, hypertension and high cholesterol. So thank you, and thanks for your time.
Welcome to the Wisconsin Nurses Association presentation on guidelines for management of persons with hypertension and high cholesterol using patient-centered team-based care. This Wisconsin Nurses Association presentation was supported by Cooperative Agreement number NU58DP006521 from the Centers for Disease Control and Prevention, awarded to the Department of Health Services Chronic Disease Prevention Program. Its content is solely the responsibility of the authors and does not necessarily represent the official views of the CDC. WNA is pleased to present these guidelines for use in primary care that include the following: a model of patient-centered team-based care that can be used in identifying and managing hypertension, high cholesterol, and other chronic diseases. These guidelines were developed by multiple teams of interprofessional healthcare clinicians and other professionals with knowledge of health systems and community connections. WNA believes that the use of patient-centered team-based care will result in better health outcomes and patient and team member satisfaction. This model is built upon the definition of multiple health professionals, which was adopted by the U.S. Institute of Medicine and reads as follows. Team-based healthcare is the provision of health services to individuals, families, and/or their communities by at least two health providers who work collaboratively with patients and their caregivers, to the extent preferred by each patient, to accomplish shared goals within and across settings to achieve coordinated, high-quality care. The model has three intersecting core elements. 1. An interprofessional team that is high-functioning who delivers patient-centered care. 2. The individual team member from a diverse workforce that comprises the interprofessional team. And 3. A systems parent C-suite that provides the infrastructure and operations necessary to develop and sustain high-functioning teams and connections to the community. In the center of the intersecting core elements is the patient. In order for patient-centered team-based care to be as effective as possible, there is the need for the patient to be as engaged in their care to every extent possible. Patient-centered team-based care promotes the transition of the patient and the healthcare provider to a philosophy of care to me, to care with me, to care by me. This level of patient engagement is critical to achieve good self-care practices and, in turn, promote patient self-efficacy. In order to be effective, the anatomy of the team includes knowledge, what we're doing, skills, how we should be working, attitudes, why we're doing our work, and shared accountability, loyalty to the concept and culture. The individual team member creates the interprofessional team. The individual team member needs to be honest, disciplined, creative, humble, and curious. It is desired that the composition reflect the demographic diversity of the community. The organizational leadership provides the infrastructure, system, operational, and resources that support the ability to achieve a high-functioning team, including durable connections to the community. The infrastructure supports the stated culture, shared vision, shared values, promotes dialogue and collaborative leadership, nurtures systems thinking and innovation. The core principles that are important to the success of team-based care include shared team and patient goals, clear roles of team members, mutual trust, effective communication, measurable processes and outcomes. The hallmarks of practice reflect core values: safe, competent, and evidence-based care, mindful of culturally and linguistically sensitive care, proactive focus on all three levels of prevention, patient satisfaction, coordinated care, facilitated use of patient registries and information technology. The triple aim of healthcare remains a driver in achieving improvement of the patient experience, quality, safety, and satisfaction, improvement in the health of the population, reduction in the per capita costs of healthcare, purposeful investment in strategies, including identification of the existing health disparities that promote effective and meaningful connections between the health system and the community that supports the health of the population. We hope that you found this information helpful to your practice and your healthcare organization. We recommend that this model be implemented in those patient populations that have chronic diseases. We will now present how this model can be used in the identification, treatment, and management of patients with hypertension and high cholesterol. A focus on the application of patient-centered team-based care for improving hypertension for patients with hypertension. Addressing hypertension in Wisconsin is important for the following reason. First, there is a portion of Wisconsinites who have hypertension but are not diagnosed. 16% of adults with uncontrolled hypertension in Wisconsin are unaware that they have hypertension. Second, less than 1/2 of adults with hypertension have their hypertension in control. 62% of Wisconsin adults with uncontrolled hypertension are seeking medical treatment but are still struggling to get their hypertension under control. Third, 90% of U.S. adults with uncontrolled hypertension have health insurance, as well as a regular source of health care. Healthcare providers have an opportunity to improve upon the identification, treatment, and management through patient education and engagement, using team-based care to improve hypertension outcomes, because it requires a partnership between the team and the patient. There is commitment from the health system leadership that team-based care improves patient and clinician satisfaction. There are connections to the patient's community that can assist in supporting the patient's understanding and monitoring of their hypertension. A panel of multi-healthcare professionals and other professionals with knowledge of team-based care delivery and primary care developed a set of recommendations for the identification, treatment, and management of patients with uncontrolled hypertension using the W&A patient-centered team-based care model. These recommendations are as follows. Establish a culture of patient-centered team-based care for hypertension detection, prevention, and control. Allow team members to practice at the top of their license and education. Establish a system-wide principle. All healthcare providers are involved in prevention, diagnosis, and treatment of patients. Improve information technology and the electronic health record to support care delivery and patient safety. Establish system-wide goals to manage hypertension using state and national quality metrics. Establish hypertension management teams to champion excellence in the prevention and control of hypertension in those undiagnosed. Improve communication within and among team members. Collaborate with the health system leadership and informational technology services to develop registries, dashboards, and other clinician-friendly systems improvements. Acknowledge, disseminate, and celebrate team success. Provide leadership that results in the creation of durable linkages between health systems and communities to improve hypertension outcomes that benefit the health of Wisconsin's population. Breaking it down, what these recommendations suggest for healthcare professionals is that 1. They work interprofessionally. A blood pressure should be checked at every patient appointment, including appointments that are unrelated to the health issue of hypertension. Take advantage of what your team members have to offer and ask them for assistance. Pharmacists can assist with medication management. Medical assistants can take blood pressure readings and implement processes and protocol if the reading is high. RNs can assess at every visit. Social workers can assist with identifying health determinants that impact the ability to control hypertension. Community health workers can assist in supporting adherence in the home. Hold regular team meetings to discuss strategies for improving patient compliance. Establish clear roles for all team members, including those community resources. Second, promote patient-centered team-based care through regular meetings that address team goals and process improvement. Create and review benchmarks that demonstrate high-functioning teams' criteria. Focus and develop a plan for improvement of processes and protocols. Explore successes and barriers to the team members working in partnership with one another and/or achieving better patient engagement. Third, provide care that is patient-centered. Patients should be involved in deciding their plan of care to increase adherence. Follow up with patients after their visit in the clinic or hospitalization regarding self-management of their blood pressure, as well as to discuss any medication adjustments. Promote self-care by ensuring the patient is educated on how to use the blood pressure monitoring equipment and on reporting their results. Fourth, bridge the gap between the community and the patient's health system facilities. Incorporate community health workers in the care. Refer patients to community hypertension support and education. Actively update the hypertension patient population registry to highlight target areas in the community that may require increased amount of hypertension education. Fifth, know and identify solutions to the health disparities that have an impact on controlling the patient's hypertension. After-visit summaries and patient education should be provided that are consistent with the patient's culture, health literacy, language, and other accommodating needs. Promote healthy lifestyle choices that support hypertension control through nutritional, physical activity levels, stress management, sleep counseling, and education. Utilize evidence-based educational programs for those patients with a chronic disease, including hypertension. Sixth, provide training to team members. Provide training on interprofessional, patient-centered team-based care prior to launch, intermittently for improvement, and with all new employees. Ensure employees perform accurate blood pressure measurement and monitoring using evidence-based guidelines at least annually. Demonstrate that the overall cost of care for the present and future can be reduced with appropriate prevention and control of hypertension. Seventh, promote services that promote patient convenience to control hypertension. Create a system for same-day, easily accessible appointments for patients with a blood pressure measurement greater or equal to 130/80. Offer free on-site blood pressure screenings for patients, caregivers, significant others, and visitors. Eighth, identify technology needs. Use dashboard alerts in the EHR to make guidelines and treatment easily accessible when an elevated blood pressure is entered into the system. Provide a hypertension registry. Use telehealth or a similar system to ensure patients can easily communicate self-measured blood pressures to the healthcare team. Support patient access to reliable blood pressure measurement equipment for self-measurement activities. Expand EHR capability to allow for community health providers to access the EHR platform. This is how we believe control of our patients' hypertension can improve using patient-centered, team-based care. We will now present how this model can be used in the identification, treatment, and management of patients with high cholesterol. Another focus on the application of patient-centered team-based care can be used for improving high cholesterol in patients. Addressing high cholesterol in Wisconsin is important for the following reasons. Having high blood cholesterol raises the risk for heart disease, the leading cause of death, and for stroke, the fifth leading cause of death. With treatment, this can be prevented. High cholesterol has no symptoms, so many people do not know their cholesterol is too high. A simple blood test can check cholesterol levels. Cholesterol travels through the blood on proteins, called lipoproteins. Two types of lipoproteins carry cholesterol throughout the body. LDL, low-density lipoprotein, sometimes called bad cholesterol, and HDL, high-density lipoprotein, or good cholesterol, that absorbs cholesterol and carries it back to the liver. The liver then flushes it from the body. 95 million U.S. adults aged 20 or older have total cholesterol levels higher than 200 milligrams per deciliter. Nearly 29 million adult Americans have total cholesterol levels higher than 240 milligrams per deciliter. The age-standardized prevalence of self-reported high total cholesterol in Wisconsin is 29.9 to 31.7%. Healthcare providers have an opportunity to improve upon the identification, treatment, and management through patient education and engagement, using team-based care to lower high cholesterol in patients' outcomes, because it requires a partnership between the team and the patient. There is commitment from the health system leadership that team-based care improves patient and clinician satisfaction. There are connections to the patient's community that can assist in supporting the patient's understanding and monitoring of their high cholesterol, including pharmacists, dietitians, and physical therapists. Breaking it down, what these recommendations suggest for healthcare professionals is that 1. They work interprofessionally. If a patient has high LDL cholesterol levels, the patient-centered healthcare team may recommend cholesterol-lowering medicine and lifestyle changes to lower the risk for heart disease and stroke. Review the 2018 AHA-ACC cholesterol guidelines that were revised and has the latest information related to treatment options. Genetics may also play a role, and risk tools have been developed to assess individual status. Assess ASCVD risk utilizing sex and race-specific pooled cohort equations. If the patient is 20 to 39 years old, it's a lifetime risk estimation, and if they are 40 to 75 years old, it is a 10-year ASCVD risk. Encourage a heart-healthy lifestyle for patients. Provide dietary recommendations for LDL lowering. Consume a dietary pattern that emphasizes intake of vegetables, fruits, whole grains, includes low-fat dairy products, poultry, fish, legumes, non-tropical vegetable oils, and nuts, and limit intake of sweets, sugar-sweetened beverages, and red meats. Encourage smoking cessation. Encourage a healthy weight. Being overweight or obese raises levels of LDL bad cholesterol, and reaching a healthy weight can help lower your cholesterol levels. Encourage limitation of alcohol. Often, lifestyle changes may need to be supplemented by medications. Reduce LDL-C with a high-intensity statin. Assess adherence and response to medication and lifestyle changes with a fasting lipid panel 4 to 12 weeks following statin initiation or adjustment, then every 3 to 12 months. Pharmacists can assist with medication management. Lab techs can draw blood. RNs can assess at every visit for educational knowledge, and social workers can assist with identifying health determinants that impact the ability to control high cholesterol. Community health workers can assist in supporting adherence in the home, and dietitians can review suggested diets. Hold regular team meetings to discuss strategies for improving patient compliance. Establish clear roles for all team members, including those community resources. It is important that all members of the team respond to questions after a prescription is given to clarify information, address adverse effects, and communicate with the pharmacist. Lifestyle counseling and providing resources is a major component of success for the patient. Second, promote patient-centered team-based care through regular meetings that address team goals and process improvement. Create and review benchmarks that demonstrate high-functioning team criteria. Focus and develop a plan for improvement of processes and protocols. Explore successes and barriers to the team members working in partnership with one another and/or achieving better patient engagement. Third, provide care that is patient-centered. Patients should be involved in deciding their plan of care to increase adherence. Follow up with patients after their visit in clinic or hospitalization regarding self-management of their high cholesterol, as well as to discuss any medication adjustments. Assess the patient's mental status and ability to maintain engagement, and make a referral to a mental health team member if applicable. Fourth, bridge the gap between the community and the patient's health system facilities. Incorporate community health workers in the care. Refer patients to community heart-healthy lifestyle education. Actively update the high cholesterol patient population registry to highlight target areas in the community that may also require increased amount of high cholesterol education. Fifth, know and identify solutions to the health disparities that have an impact on controlling the patient's high cholesterol. After-visit summaries and patient education should be provided that are consistent with the patient's culture, health literacy, language, and other accommodating needs. Promote healthy lifestyle choices that support high cholesterol control through nutritional, physical activity levels, stress management, sleep counseling, and other education. Utilize evidence-based educational programs for those patients with a chronic disease, including high cholesterol. Sixth, provide training to team members. Provide interprofessional patient-centered team-based care training prior to launch, intermittently for improvement, and with all new employees. Ensure accurate high cholesterol measurement and monitoring using evidence-based guidelines. Most healthy adults should have their cholesterol checked every 4 to 6 years. Demonstrate that the overall cost of care for the present and future can be reduced with appropriate prevention and control of high cholesterol. Promote education that promotes patient compliance to control high cholesterol based on current cholesterol levels and risk of heart disease and stroke. Seventh, monitor the risk. Monitor risk-enhancing factors and make appropriate referrals to team members if the patient has a family history of premature ASCVD, metabolic syndrome, chronic kidney disease, a history of premature menopause in ages 40 years or under, chronic inflammatory disorders like rheumatoid arthritis, psoriasis, or chronic HIV. If the patient is in a high-risk ethnic group, persistent elevations of triglycerides greater than or equal to 175 milligrams per deciliter. Eighth, identify technology needs. Use dashboard alerts in the EHR to make guidelines and treatment easily accessible when a high cholesterol is entered into the system. Providing access to the cholesterol ASCVD risk estimator can be used to estimate lifetime risk in young adults. And here you can search the ASCVD Risk Estimator Plus. Promote interventions to assist compliance, telephone reminders, calendar reminders, multidisciplinary educational activities, and a simplification of drug regimen. Expand EHR capability to allow for community health providers to access the EHR platform. In closing, utilization of the following checklists may provide some assistance in utilizing the model. The checklist for implementation of patient-centered team-based care is pre-visit planning, a structured or standardized pre-visit planning and anticipation, and planning for upcoming patient visits, including the method, team meetings and huddles, structured communication, dashboard in the EHR, checklists, and appointment notes. For workflow or standards of care, a structured or standardized coordination of care with labs, specialists, institutional settings, or other care facilities, including referral tracking and follow-up, test tracking and follow-up, and care transitions. Make sure to integrate and include the patient, family, or caregiver as part of the team. A standardized or structural integration for community health workers and community pharmacists into the delivery of health services using a team-based care approach. And make sure to ensure warm handoffs, clinical decision support tools, shared goals, and mutual trust. For communication processes or sharing methods, a structured communication process or holding regular team meetings, such as huddles, for sharing patient information, care needs, concerns of the day, and other information that encourages efficient patient care and practice workflow. Establish bi-directional feedback with healthcare providers and teams and healthcare extenders. Having the healthcare team, provider, and patient involved in identifying treatment goals and self-management plans. For structure, responsibilities, and training, team-based care structures that include staff that are trained and assigned to manage the patient population. Structured tasks and stated staff responsibilities for all staff involved in the care of the patient. Having staff functioning at the top of their license or role and matching skills, abilities, and credentials. A standardized method to routinely assess training needs, ensuring the staff is appropriately trained for their roles and responsibilities, and providing cross-training to ensure that the patient's needs are consistently met. An identified clinician lead and a team-based care lead manager to lead and facilitate implementation. Holding scheduled team meetings to address practice or team-based care functioning outside or in addition to meetings to discuss patient care. And for quality improvement, staff involvement in quality improvement that includes care team staff in the practice's performance evaluation and quality improvement activities. Thank you for the opportunity to provide you with this information. More questions on patient-centered team-based care can be directed to the Wisconsin Nurses Association at wisconsonnurses.org.